I'm pretty much getting ready to get settled into this clear liquid diet and get settled into the bathroom. Starting at 6, it's movie prep time. Movie prep time. I have all of my literature to read in the bathroom.
Do you have any other questions?
Yeah, do you know which, I'm going to be laying on my side for this?
You're laying on your left side.
On my left side?
Yes.
Okay. All right, I need to take care of something here. Hang on. Go out of here. Let's see. Does anybody have a Sharpie? Anybody?
I have a Sharpie.
Do you have a Sharpie? Are you with somebody?
Yeah, but I got time.
Okay.
Can you borrow it?
Yeah, I need you to, can you write something on my side for me?
Sure.
Okay. Follow me.
Okay.
Okay, so, wow, that's a big Sharpie.
Yeah, it
Nice.
is.
You always carry big Sharpies like this with you?
I was just watching Let's Make a Deal.
Okay. All right, well, here's what I need you to do. I need you to write on me an arrow pointing to my butt, and then enter here.
Okay.
Okay? So, on the right side here, yeah, like right here, yeah, just an arrow, so the doctor will know where. I get nervous about these things. I don't like things in my ears, and I don't know this guy well enough for anything else. So I know he's a good guy. I'm sure he's a credible doctor, but I just want to make sure that he has some guidance here, and that we're both on the same page.
Worry about her infection from the scope. It's very, very rare bleeding, especially if you take any blood thinners like Coumadin, warfarin, aspirin, Plavix. Do you take any of those? Okay. If we take any biopsies or fetting polyps off, we'll make sure all the bleeding stops.
Okay.
There's a risk of what's called a perforation or causing a hole somewhere in the colon. That's very rare, about 1 every 2 to 3,000 cases. We don't expect anything like that to happen, but of course we need to let you know about it before you.
Okay.
Okay?
All right.
Do you have any questions? We'll get you back soon, okay?
Okay.
Hey, pleasure to meet you.
Good to meet you.
And the majority of the examination is actually performed on the way out, not the way in. Of course, we will be looking for any large polyps or anything that's abnormal on the way in, but we'll get the better work on the way out. So far, everything looks okay. So this is the sigmoid colon, which is the curviest part of the colon. That's some of the leftover prep that I'm sucking out. We have a suction channel on our scope. She did a great job cleaning herself out. So throughout the procedure, we'll put scope in, take scope out, lengthen the scope, shorten the scope. Like I said, we're just trying to get to the end of the colon right now. So this is actually the appendiceal orifice. It's a crescent-shaped structure. The appendix is on the other side of the wall there. This is the cecum of the colon. Everything looks good right here. And then the small intestine actually comes into the colon right here. So I'm going to go up into the small intestine, take a look, make sure everything looks okay. This is when people say they have Crohn's disease, there's usually inflammation in this area. So you can see how much smaller it is because it's the small intestine. Everything looks normal here. And then this is the ileocecal valve there about 7 o'clock or 8 o'clock. And that's where we just went in. Now the exam actually is very important from this point on because we'll be looking for anything abnormal. Be looking for polyps or inflammation, which we did not see any on the way in. We'll take a good look. The GI societies actually have started a task to have us take at least 6 minutes on our withdrawal time to fully evaluate the colon and make sure that there's no polyps. The average, what we call adenoma detection rate in females is 15%. Just looking behind all the folds, cleaning as we go. Biopsy procedure. So she's got a tiny, small little polyp right here. We'll remove it with biopsy forceps. Open. Close. Now we're coming down the very bottom of the colon. We'll evaluate for hemorrhoids. This is called a retroflex view, where we turn around and look on the inside. Everything looks good there. And we are done.
Okay.
So, one tiny little polyp in there. We've got it completely out. We'll send it off to the lab and see what they say.
Okay.
It doesn't look like a polyp that would ever turn to cancer. It looks like what's called hyperplastic polyp. But nothing dangerous. There's no active inflammation anywhere. I can't find a reason why you're having this discomfort or this pain.
Okay.
So no colitis or inflammation of the colon.
All right.
And you don't even have those little pockets in your colon that 30% of 50-year-olds have.
Really?
No hemorrhoids either.
Okay.
Especially even after doing that prep.
So the polyp, like where is it?
It's on. It was in the sigmoid colon, which is on the left side, and it's down towards the bottom of the colon.
Okay.
Any questions?
What usually causes polyps?
It's mutations in genes,
Okay.
and usually it takes a couple different mutations over a period of time. Sometimes there's a genetic component. People that get polyps, thousands of polyps by age 30, called like FAP or familial adenomatous polyposis syndrome. So it can be many, many different things.
Okay. So it doesn't really have to do with diet then?
There are studies that show high meat diets
Uh-huh.
can be worse, and some people say even smoking can.
Okay. All right.
So you don't need another colonoscopy. If this polyp is something that would never turn to cancer, you don't need another colonoscopy for 10 years.
Okay.
That's the newest recommendation.
All right.
Any questions?
No.
Okay, it's a pleasure to meet you.
All right. Thank
Okay.
you.
Have a good dinner.